Thanks, Evelyn. My name is Evelyn. I'm a clinical specialist physio here. I just want to thank Sean O'Dowd for asking me to talk on the small topic of atypical Parkinsonism, which is a mean feat to achieve in 30 minutes, but we'll see how we go. So I thought I'd start by saying, wait, this is a dementia study day. Why are we talking about Parkinsonism? And I suppose really where this comes from is when I started in my role as physio in the memory clinic, the biggest question I was asked every single time was, well, why do you need a physio in a memory clinic? And I suppose what we've come to realise over the last few years is that for a lot of patients who present to memory clinics, their leading symptom may be motor or maybe cognitive. And something that we're seeing more and more of in our clinic is patients who may present with kind of subtle frontal cognitive and behavioural symptoms that then go on to develop significant motor symptoms. And really that we're doing these patients a significant disservice if we're not able to recognise them and, as Sean said, give them that diagnosis that the majority of patients come looking for. So I suppose that the aim of this talk today really is to talk about atypical Parkinsonism, but really to focus in on the kind of more behavioural and cognitive elements that you might expect to see in some of these cases, but also to kind of highlight that it's not straightforward for a lot of these patients. A lot of patients will present with a variety of symptoms that come under lots of different umbrellas. And that it's important that we really listen to what the patients are saying to us to come to a kind of an accurate diagnosis. And also that we're quite lucky for a lot of these syndromes that we have very clear clinical criteria that we can refer back to. But some of the research shows as well that for a lot of people they don't fit in one box. So some patients might look for a diagnosis, but it might be a little bit of time before they get an accurate diagnosis, and the importance of following those patients over time and listening to them and then managing them appropriately over their kind of disease trajectory. So when we talk about atypical Parkinsonism, really we're talking about sporadic neurodegenerative disorders comprising about 15 to 20% of Parkinsonism cases, and they're heterogeneous and they differ from IPD due to their clinical and pathological features as well as their genetic variabilities. They're characterised by a poor response to levodopa, progressive Parkinsonism, and varying combinations of motor and non-motor symptoms, including autonomic and cerebellar symptoms, and they can be associated with cognitive, behavioural, and other neuropsychiatric disturbances. And many of these symptoms may be present in the early phase of the disease and also frequently anticipate motor symptoms. And cognitive dysfunction is one of the main factors that determine low quality of life for both patient and caregivers, and they should be assessed as early as possible in the assessment process. So when we talk about Parkinsonism, really, there's two main kind of culprits at play. Alpha-synuclein, which is responsible for IPD, DLB and MSA. So Sean is going to touch on DLB, and I'm not really going to touch on MSA because we know for these patients only about 20% of them present or have cognitive difficulties over the course of their disease. So really today I'm going to focus on the tauopathies with a little asterisk that for those with CBD or CBS that their pathology may not be tau, but the clinical syndrome is of that of Corticobasal syndrome. So if we start with then progressive supranuclear palsy, it's a Parkinsonism with prominent axial features and postural instability. Those patients tend to have supranuclear gaze palsy, dysarthria, dysphagia, and frontal dysexecutive cognitive impairment. In terms of prevalence, it affects about 1 to 18 per 100,000, and the average time to diagnosis is about 3 years. The mean survival time is approximately 7 years, and poor prognosis is associated with an older age of onset, early dysphagia, cognitive decline, and a rapid disease progression. So generally, a lot of these patients would present in their 60s, and they would see what a lot of the evidence would say they'd see at least 2 physicians prior to getting a diagnosis. So some of these patients can go through several services before they're kind of pinpointed to the right direction. So PSP is a clinical diagnosis and has very clear diagnostic criteria, which is outlined in the International Movement Disorder society. I suppose the classic PSP that you all will be familiar with is that form PSP-RS, or Richardson syndrome, which is that more classic picture of axial predominant levodopa unresponsive Parkinsonism with early postural instability and recurrent falls, ocular motor dysfunction, dysarthria, executive dysfunction and behavioural changes. But there are increasingly recognised clinical phenotypes that differ from Richardson syndrome, and what we know is that approximately 50% of patients with PSP pathology may present with a varying phenotype. So when we look at these kind of varying phenotypes, we can break them down into those that are cortical and those that are subcortical. So in the cortical group, we have those who present with more frontal, corticobasal or speech and language-led disorders. And in the subcortical group is more those with Parkinsonism, progressive gait freezing, ocular motor dysfunction and postural instability. So this study really highlights the variety and the complexity of presentation and how the disease course progresses. So this is a study that they did in the UK where they looked at 100 autopsy-confirmed cases of PSP, and what they found was that of the phenotypes, only 24% their first symptoms were those that were kind of classically under the Richardson phenotype. And when they looked further at the kind of medical notes for these patients, they found that a lot of patients had significant overlap between different symptoms. So you can see there they've broken it down to FTD, cerebellar symptoms, ocular motor, postural instability, progressive gait freezing, Parkinsonism, corticobasal syndrome, and then progressive non-fluent aphasia. And when they looked and they kind of subtyped them then further, again, it was around 24% that their initial presentation was in keeping with Richardson, but there was a much wider variety of patients who fit into different groups. And I suppose what this really highlights is that some patients might start with a leading symptom, but over the course of their disease develop multifactorial or different symptoms as they go. And that's why it can sometimes not be helpful to give someone a very specific label. So if we look then into the kind of more cognitive and behavioural aspect of things, so this is taken from the diagnostic criteria, and that's where they first mentioned the idea of cognitive dysfunction being an issue in these patients. So if we look at cognitive dysfunction in PSP, what might you expect to see? So generally patients present with a kind of attentional dysexecutive symptoms, and they might be among the earliest presenting symptoms of the disorder, and they can start kind of between more than 3 and up to 10 years before the patient gets a diagnosis. For anyone who's managed patients with PSP, something that's quite striking is their delayed processing speed. So a lot of these patients will present with kind of profound bradyphrenia that can be really, really challenging for patients and for their families to kind of get their heads around. In the early stages, about 50% of patients present with cognitive impairment, and about 40% of those have executive dysfunction. Verbal fluency is among the most frequently impaired executive function in PSP, and it's strongly associated with that kind of midbrain atrophy. And then in terms of other cognitive domains, memory, naming, construction and visuospatial abilities and social cognition can also be affected. I suppose why is it important that we recognise these symptoms is that there's a lot of evidence to say that the more cognitive and behavioural symptoms can impact significantly on carer burden and also the patient's experience of the disease. So we took a little bit of look at some of the behavioural symptoms that we tend to see in PSP, and those would be kind of apathy, which tends to be quite profound, impulsivity, behavioural rigidity, a lot of rigidity around fixed behaviours, perseveration, and then change in social cognition, so things like loss of empathy, change in personality. And when we see patients coming through clinic, these are the things that really tend to impact on patients, more so on their family members, and can be really, really difficult for them to get their heads around. Especially things like apathy, because they feel like it's something that the person can control, and it's just that they're not bothered really, as opposed to it being something that's quite pathological and quite difficult to manage as a disease progresses. So we have some quite nice research closer to home And this is a study that we looked at through the Leinster Tauopathy study, where they had 19 participants with a diagnosis of PSP or CBS and 17 caregivers. And what we found was that a significant portion of caregivers described their role as stressful, citing physical strain, fatigue and emotional challenges. These difficulties were often linked to the physical care demands and the behavioural or cognitive symptoms of the patient. Over 70% of caregivers reported observing a change in their relative's personality. And what's really interesting here is those with MoCA scores of under 20 reported higher levels of caregiver burden severity. Things like sleep disturbance, physical strain, changes in personality were rated as moderate to extreme concerns in this group, and perceptions of inadequate support were more pronounced in the kind of low cognitive group as well, with about 45% identifying it as a moderate to extreme problem. So we know that the impact of cognitive and behavioural dysfunction is significant on both patients, but more so on family members who are providing the majority of the care for these patients when they remain at home. So just to bring you through the concept of a patient journey not being straightforward, I thought it might be nice now to look at a case study. So this is a case study of a 63-year-old gentleman who presented to neurology following a referral from OC Health in May 21, where there had been concerns around his ability to do his work. At the time, his kind of clinical features were, in terms of cognitive testing, his ACE was 85 out of 100, but his profile was very much in keeping with kind of a frontal dysexecutive profile. He had significantly disordered nighttime sleep. Collateral from his wife revealed that there was significant impulsive behaviours, very rigid around a routine, had to eat meals at certain times, eating the same meals every day. He was big into running, but running became something that nearly he couldn't control, so he was having to run the same route every day, leave at the same time, very significant behaviours. So if we look at that time, he was kind of presented with more of an FTD phenotype. There was no motor symptoms observed. It was a very significant frontal kind of dysexecutive profile. But following this patient over a number of years, we can see how his disease progressed. So about a year later, there was the emergence of very subtle motor symptoms. So I think he'd had maybe one fall. His running speed had slowed down. In terms of ocular motor dysfunction, there was a slowness in his saccades. But there was no axial rigidity or bradykinesia or any other Parkinsonism. In terms of his gait, there was a slightly reduced arm swing, and he wasn't able to tandem walk, but he was still running his 5K every day, albeit at a slightly slower speed. If we fast forward then a few months to September 22, the motor symptoms had progressed quite significantly, so falls were becoming much more of a feature. He was having about a fall a week. Apathy had started to emerge as quite a significant feature. He was sent for a DAT, and that came back positive at that time. Other things that started to emerge was actually that he started to develop one-sided praxis difficulties. There was some upper limb posturing, so we're starting to see a little bit more of a kind of a CBS kind of feature creeping in. If we look then to the February the following year, and that's when the motor features really began to declare themselves. So at that point he had developed a supranuclear gaze palsy. Speech had become significantly affected with dysarthria and dysphagia. Praxis had become a much more profound difficulty, so he wasn't able to use things like his remote control on his television. He wasn't able to use white goods at home, and he'd previously been quite proficient at those things. Again, apathy is a significant feature. There's also kind of emotional ability creeping in, and reduced kind of social cognition had become a significant factor. And then if we take what he was like at the start of this year, effectively he'd become completely immobile. So he was requiring the assistance of 2 carers to transfer from chair to bed to toilet, using a Sarah steady, so not active in his transfers, fully dependent in terms of personal care and feeding, having significant issues in terms of speech and swallow, completely anarthric. that left side had really progressed in terms of profound apraxia, significant posturing difficulties with axial rigidity and tone. So you can see over the course of 4 years there'd been a significant progression in his symptoms, and really he is in keeping with that kind of PSP-CBS phenotype, albeit that it was very FTD-led initially. And I suppose what this case does highlight is the importance of keeping a close eye on someone as they progress over the course of their disease. If we had maybe discharged him in 2021 with a diagnosis of FTD, he wouldn't have had access to close monitoring, to continuity of care, but also to the many members of the MDT that are important with these patients. So you can see over a relatively short period of time, things can change quite quickly. And it is really important to keep an eye on those symptoms as patients go. Just to touch briefly on pharmacological management, patients, as I said, present with a lot of motor and non-motor symptoms, Parkinsonism, dystonia, apathy, bladder symptoms, mood, drooling can be a big problem, constipation, eyelid apraxia, sleep disturbance being quite a big feature in a lot of these patients, and cognition. And it really is down to management on a kind of very individual basis, taking these things into consideration individually and then the person as a whole. And you can see that they can be quite complex to manage in terms of the different symptoms that patients might experience over different time points in their disease course. And in keeping that in mind, this is taken from the PSP Association in the UK. So they looked at the different needs of people with PSP and CBD over there. And you can see that it's not just a 1 or 2 member team, that there's multiple members of a team involved. And while a lot of these patients will require services both in the hospital and closer to the community, I think what's important to highlight here is the importance of having a specialist service kind of at the hub of the person, and then being able to link out with the community and community services being really, really important, so that it's kind of that kind of hub and spoke model that the person would access their specialist services, and that there'd be really good communication between the different members of the MDT that can be involved in managing these patients. So moving on then to Corticobasal syndrome. So what is it? We know it's a disorder of movement and cognition with several possible underlying pathologies. It presents insidiously and is slowly progressive, and over time it has evolved from being considered predominantly as a movement disorder to a condition spanning a wide range of cognitive and motor manifestations. And when Salpetra looked at a case series, he found that 54 presented to a cognitive clinic, and 46% of these patients presented to a movement disorder clinic. And that would really link in with the initial presentation of some of these patients being very much motor-led and others being very much cognitive-led. So what is CBD and what is CBS? And this is what can sometimes be confusing in some of the literature. So what we know is that CBD is a primary tauopathy, but generally can only be given as a diagnosis post-mortem when we looked at the brains of these patients. Corticobasal syndrome really it describes a variety or a spectrum of disorders really that can have other causes, for example Alzheimer's disease or TDP-43. So really what we tend to do if the person fits in with the clinical picture is that they'll be given a diagnosis of corticobasal syndrome. And typical features include progressive asymmetric limb rigidity, apraxia, dystonia, myoclonus, cortical sensory loss, or alien limb phenomenon. In terms of the diagnostic criteria for CBS, Armstrong produced this in 2013, and it would describe patients with insidious onset and gradual progression, that symptoms should be present for at least 1 year, and the age of onset should be over 50. In terms of those with a very motor-led presentation, what you tend to see is an asymmetric presentation with 2 of limb rigidity or akinesia, limb dystonia, and limb myoclonus, plus 2 of orobuccal or limb apraxia, cortical sensory deficit, or the rarer seen alien limb phenomenon. But then you also will have patients who don't present with a kind of a motor-led syndrome, and those might present more with a frontal behavioural spatial syndrome or a non-fluent aphasia with one of the above features. And I think Lisa is going to discuss the non-fluent aphasia later on this afternoon. So what we might see in terms of clinical features along the disease course. So if we look at the different pathologies, this kind of graph illustrates nicely the difference to what you might see for someone who has an AD-led pathology versus those who might have a CBD-led pathology. So for those with AD CBS, things like myoclonus, aphasia, memory impairment and hallucinations can be more features and more prominent along the disease course, whereas for those with the CBD pathology, you tend to see more dystonia and falls in that population. And I suppose, why is it important that we know the biological background for these diseases, really? And that's because now, in terms of management of Alzheimer's disease, things have come on in leaps and bounds in the last number of years. We now have things like cholinesterase inhibitors and coming down the line, hopefully disease-modifying therapies for these patients. So really it is important to try and get someone a biological diagnosis if we can. And if Alzheimer's is the cause, we want to know that as soon as we can. In terms of the cognitive profile, impairment involves the majority of the cognitive domains, so executive function, attention, processing speed and working memory. But CBS tend to have more posterior brain involvement compared to PSP, so they have more memory problems, and that's especially if Alzheimer's disease is the underlying cause of the syndrome. They tend to have more visual perceptual problems with wayfinding, and more issues with things like arithmetic. So now we're going to look at a case study of a patient who presented to the RSMC here. And this is a 68-year-old lady who presented with memory loss for 1 year and concerns from her family. At the time of referral, her MMSE was 23 out of 30. Subjectively, she had a 1-year history of difficulty getting words out. She found that really embarrassing. She found that maybe her memory wasn't as good since COVID, so that might have been more than a 1-year history when we pipe into it a little bit more, and she was noticing that she couldn't write anymore. In terms of her family, they found her to be quite apathetic. She was regressing socially. They found her extremely quiet, more anxiety, and she'd stopped cooking, and there was about an 18-month history of language impairment, words dropping out of her head, and that was especially noticeable on the phone. So if we look at then her cognitive testing, I won't go through it all, but you can see in terms of her Addenbrooke's assessment here, significant difficulties in the areas of attention. And when we look at her fluency, a little bit more impaired in category fluency versus letter fluency. Her immediate memory is quite impaired, so you can see that on the address task. And then if we focus on the writing, this is someone who was able to read and write, but significant impairment in terms of her sentence ability at that time. Picture naming was also quite impaired, having significant difficulty with language, and you can see then in terms of her visuospatial skills, a significant impairment across all domains. When we look then at the end of the test in terms of her delayed memory, her recall was 0 out of 7 and not much coming back on prompting. So really, from a cognitive perspective, this lady has global impairment across all domains, most significantly in the areas of kind of attention, memory, language and visuospatial. When we had an MDT assessment in terms of her SLT, they found it was kind of a mild to moderate language impairment, really impaired across the board, lots of grammatical errors, and a lot of disfluency as well. OT completed a functional assessment, and they found both her ADL motor and process score were below what you would expect. And from a physio perspective, the onset of motor symptoms had been kind of in the last 6 months. She had significant praxis impairment, postural instability, and her gait was quite significantly affected. So given both the evidence from the cognitive testing and the MDT, there was a suspicion that this might be someone with the corticobasal syndrome due to Alzheimer's disease. So this lady was sent for a lumbar puncture. And maybe not surprisingly, that came back as being quite positive. So in terms of management of CBSAD, this lady had then a post-diagnostic review with her A&P. She was commenced on donepezil. She had MDT referrals. There was a power of attorney discussion that happened with her SLT, which is very important for patients who have communication impairment alongside a cognitive impairment. She was provided with written information around corticobasal syndrome, referred to the Alzheimer's Society, and had a dementia advisor and MTR referrals. So I suppose just to round it all up, take-home message really, patients with atypical Parkinsonism experience a cluster of symptoms: physical, cognitive, psychiatric and autonomic. Cognitive and behavioural symptoms may often predate any motor symptoms, and the importance of a strong collateral identifying when the person was last normal and identifying the first symptom they noticed can provide valuable diagnostic clues. The test of time is really important, and often these patients don't form a linear trajectory and require close monitoring and follow-up, and can often require access to different members of the MDT at varying time points during their management. Thank you.